Bienvenue à la session scientifique du Département de médecine familiale de l'Université d'Ottawa. La session se veut bilingue. Vous êtes invité à poser vos questions dans la langue de votre choix. Bonne session! Cette présentation sera enregistrée et disponible sur la chaîne YouTube du Département de médecine familiale. En poursuivant la session, vous consentez à être enregistré si votre caméra ou microphone est activé. This session is being recorded and will be posted on the Department of Family Medicine YouTube channel. By continuing the session, you are consenting to be recorded if your camera or microphone is activated. Nous sommes réunis aujourd'hui à partir de nombreux endroits différents et dans un espace virtuel. Mais nous désirons commencer par reconnaître les terres sur lesquelles se trouve le département de médecine familiale de l'Université d'Ottawa, qui font partie du territoire traditionnel non cédé du peuple Anishinaabe algonquin. Nous vous invitons à réfléchir à votre propre emplacement au Canada par rapport au territoire où vous vous trouvez aujourd'hui. Nous reconnaissons aussi les gardiens des savoirs traditionnels, jeunes et âgés. Nous honorons leurs courageux dirigeants d'hier, d'aujourd'hui et de demain.
Nimanajiananig, mamiwinini anishnabeg, ogo ka nagadawabandajig, iyo aki eko weshkad, akonongum egawikad ki migiwewaj. Nimanajiananig kakina anishnabeg undaje kaye ogog kakina eniagizijig, enikukamigak kanadang eje udapinagig endawajin udawang.
We are gathered today from many different locations and in a virtual space, but we wish to begin by recognizing the land on which the Department of Family Medicine at the University of Ottawa is located, which is part of the traditional unceded territory of the Anishinaabe Algonquin people. We invite you to think about your own location in Canada in relation to the territory where you find yourself today. We also acknowledge the traditional knowledge keepers, both young and old, and we honor their courageous leaders, past, present, and future.
Well, good morning, everybody, and welcome to the May edition of Family Medicine Ground Rounds. My name's Doug Archibald. I'm the Director of Research and Innovation for the department, and I'll be today's moderator. We have two speakers today from the Civic campus, and that's Dr. Anna Wilkinson and Dr. Gary Viner. Dr. Wilkinson will be speaking first, so I will introduce her. Dr. Anna Wilkinson is a family physician with a special interest in oncology. She's an associate professor in the Department of Family Medicine here at the University of Ottawa, and is our program director for the third-year family practice oncology program, and is also regional cancer primary care lead. Anna's research interests include the intersection of cancer care and family medicine, specifically screening, survivorship care, and knowledge translation. And to this end, she authors and edits the oncology briefs in the Canadian Family Physician. In her spare time, she tries hard to keep up with her 4 teenaged athletic daughters. So Anna, I will now hand things over to you and look forward to your presentation.
So thanks very much. I'm thrilled to be here today. As Doug said, I am a family doctor, but also a GP oncologist. And so I think that's really what lets me do the research that I do. Eric Woltorton gave me this great book to read called Range. And in that book, they talk about how, as a generalist, you see things that other people don't see, and you're able to, whereas specialists are in silos and they're not necessarily seeing the big picture, you're able to kind of connect the dots and see the gaps that need filling in. And so that's kind of how I see myself and how I see the research that I'm doing. It's stepping back, kind of looking at the big picture of the intersection between family medicine and cancer, and looking at the gaps and how to fill them. And the dots I'm connecting are, as you see here, family medicine, cancer care, data from Statistics Canada, and working with a digital technology company called Thrive. And I put the DFM up in the little corner there because I have to thank them very much for my locum support fund, which the 10 days there really let me do the work that you're going to see today. I also have to give a shout out to my colleagues who helped cover while I was off for those 10 days. So the gaps that I've seen and the research that I'm doing looks at the impacts of cancer screening. How do we optimize our cancer screening practice? What about the cost effectiveness? We all know that that's an important thing to think about in our system today, and survivorship care. And so today I'm going to do a whirlwind sort of touch on all of the different projects I'm involved in. Each one of these could be a whole session in itself, but I just wanted to give a sense of, again, the range of things that are going on. And I'm happy to speak to any one of these in specific in the questions. So the first thing I'm going to talk about is my work with Statistics Canada. So I partnered with Statistics Canada to use the Canadian Cancer Registry. And so this is a huge untapped resource of data that we really haven't used to this point, more than just to report, our cancer rates are X. And so along with Dr. Seeley, I started working with them to say, look, you have this big data collection. I have the clinical expertise to know that these are the specific questions that we need answering. Can we mesh this clinical knowledge and the data and try and come up with some answers for some of the questions that I have around screening and screening practices? And so there's many projects that we're involved in. One of them specifically is looking at breast cancer screening in women in their 40s. Since the task force recommended against screening in 2011. And with that, different provinces and territories chose to either continue screening or not screening. And so we've almost been running a natural experiment in our country for several years where there are jurisdictions that screen and jurisdictions that don't. And so we're able to leverage those differences in screening to see what are the impacts. And so we've looked at the impacts on stage of cancer at diagnosis and on survival for women in their 40s. The other thing we're able to leverage with those differences is how does mammography pick up different subtypes of breast cancer? Because to say that, we're screening for breast cancer is really a misnomer, because breast cancer has many different diseases. There's triple negative, there's HER2 positive, and so does mammography work equally well for all those kinds of breast cancer. The other projects that we have on the go are my gurus. The beautiful thing about this partnership is I have a couple of guys that I have on speed dial from StatsCan. They are infinitely familiar with the database and different things that they can mesh with it. And they are statistical gurus, so I don't have to know the in-depth stats. So I said to them, can we really figure out what's going on with unattached patients and what's going on with cancer outcomes? Because we know this is a huge problem. And they said, yeah, we have this community health survey, and in it, people have had to say whether they have a doctor or not. So we can fuse these two things and figure this out. Same thing with impact of race and ethnicity on cancer stage at diagnosis. They can mesh the census data with the cancer registry. And so those projects are ongoing, and we have so many ideas for more projects. So this is a quick look at one of the studies that we published last summer. We looked at, again, that jurisdictional difference in screening for women in their 40s. And what we found is in screener provinces, so those are the blue ones, that the stages of cancer were much more advanced in provinces that don't screen. So if you are a screener, you have higher proportion of stage 1 cancer at diagnosis, lower proportion stage 2, 3, and 4. But then I went to my StatsCan guys and I said, on the wards, I'm taking care of lots of women in their early 50s with metastatic disease. So could it be that if we're not diagnosing these cancers in the 40s, they're appearing in the 50s at later stage? So can we run this analysis for women in their 50s as well? And lo and behold, we found the same thing. So stage 1 increase women in their 50s, stage and more stage 2 and 3 if you're not screening. The other thing that we found when we looked back temporally is that after the guidelines changed in 2011, we found a 10% increase in stage 4 breast cancer diagnosis in women in their 50s. So this study has had a lot of impact. There's been a lot of media attention. I did an interview last Monday with Dr. Theriot from the Canadian Task Force on CBC Morning. Had lots of different CBC interviews. It was quoted in the Globe and Mail. But more importantly, it's actually been used to inform screening guidelines. And I went to Parliament, presented to the Liberal Women's Caucus so that they're aware of what these implications are. Alberta used this data in part to lower their screening age to 45 recently. And lots of provincial cancer organizations are looking at this data to help them figure out what to do. But my favorite part of this study is I got an email from one of the breast surgeons that I know who said, hey, I went to the American Society of Breast Surgeons. And guess what? In one of the plenary sessions, when they were presenting all the new studies, your study was the very first one they presented. So I was kind of proud that a family physician's paper was the #1 paper at a breast surgeon conference. I bet that doesn't happen very much. This is the follow-up paper from that. I was just working late last night on the second review, so I think fingers crossed should be accepted within a short while. And this is a study that looked at then the next step on from stage. So what is the impact on net survival? So I'm not going to go through it all because it's not out in the public yet, but I will let you know that there was a significant impact on survival for women aged 40 to 49 if they weren't screened. This is our paper that's in the works right now. So basically, from the clinical perspective, I went to my StatsCan guys and I said, you know what, to talk about breast cancer just as one disease doesn't make sense. Can we find a way to parse that cancer registry data into the molecular subtypes? Do we have the information available? And they said, well, we have, ER status, we have HER2 status. I said, okay, that's enough. We can figure this out. And so with this, we were able to develop or separate out these data into molecular subtypes. And we've been able to figure out a picture of what breast cancer looks like in Canada for women across different ages and subtypes. And this isn't something that we have known before this point in time. And using the screening differences between 40 and 50, we've then been able to say, okay, what does this look like in terms of mammogram? What's showing up on mammogram and what's not? So again, this is still very much in process, but I think it's going to shed a lot of light onto, when we say mammogram is working or not working, is it because it's picking up specific subtypes of breast cancer? Is it because it's not working for dense breasts, which are typically more ER positive? So all of these factors we're looking into. Another spin-off project from the STAGE project that was published last summer was this project. And this is very much, again, in the works right now. But the Canadian Partnership Against Cancer came to us and said, hey, we saw your stage shift due to screening. We'd really like to plug this into our OncoSim model and figure out cost effectiveness of screening. And we said, sure, that sounds like a great idea, but what are the numbers in your model? And CPAC showed us their model and showed us the numbers, and they were costing a stage 4 breast cancer treatment at $11,000. And certainly being in the field, I know that that is not anywhere near remotely correct. And this is what they're basing cost effectiveness of screening on right now. And so it became very apparent that we don't actually know what it costs to treat all the different stages and all the different subtypes of breast cancer. And without this information, you can't really develop a good sense of what is the cost of the system, what's cost effective to do. Because, logically, in my mind, if you catch a cancer earlier, it's going to be far cheaper to treat. But we can't prove this until we know the actual costs of what it costs. So together with Dr. Jean Seeley, we developed an expert group. So we pulled together, again, with my range, I know specialists in all these different areas because I work with them. So we pulled together a pathologist, a surgeon, a radiation oncologist, medical oncologist, and we have a modeler that Dr. Seeley knew. And so we've been working on an activity-based costing which is almost done. This is not the final version. I think in a couple of weeks' time it will be done. And if you look at this graph here, we've got cost on the y-axis, and then stage. Blue is stage 1 back to stage 4, which is green, and then the different subtypes. And so what our preliminary findings are showing is that a stage 1 breast cancer costs about $20,000 to treat. A stage 3 is around 80 to 100,000, and a stage 4 is around 500,000. So this is really different than the $11,000 that our system is currently using to model this. So our plan is, once we publish this, to then feed this into the OncoSyn model and look at what is the cost effectiveness of screening, what's the cost effectiveness of supplemental screening for women, say, with dense breasts, and really understand the implications, because my feeling is a $68 mammogram is going to look pretty good compared to a lot of these costs. So shifting gears a little bit, this is the other big project I'm working on, and this is in the survivorship realm. And again, I said I'm doing a whirlwind tour, so we're going quickly through these, but I'm happy to speak to any questions. So this is the Survivor Advisor is a digital tool that I've worked to develop with Thrive, who is a digital health technology company. So essentially, we took the breast cancer survivorship tool, which was a paper tool published in the Canadian Family Physician, and turned it into a digital app. So what this app does is it is a digital journey that supports a patient in their survivorship care. So the patient is invited to it when they finish their treatment, they make an account, they put in their data, the clinician puts in their data, and it creates a customized survivorship care plan based on the treatment they've had. So for example, if you've had a bilateral mastectomy, you don't need mammograms, so you wouldn't get reminders for that. If you're on an aromatase inhibitor, you would need a bone mineral density, so you would get reminders for that kind of thing. And this tool is designed to be linked with Epic. That's still in process because these things take a really long time. So essentially, it works in 4 steps. So step 1 is that it creates this care plan for you. And this is what it looks like. There's a patient dashboard, there's a clinician dashboard, works on phone, tablet, desktop. We've gone through TOH privacy and security, which, believe me, is not for the faint of heart. And essentially what happens is, along this care plan, which has a customized sort of cadence of key care points that the patient needs, they get email reminders. And then when they click on that email, it takes them to their patient dashboard, and it says, hey, have you booked your mammogram? Hey, have you done your breast self-exam? Are you having any side effects? So that's kind of how it works. The clinician dashboard piece is totally customizable. And so you can either be notified of all the things your patients are doing, or you can turn it off if you don't want to be kind of responsible for them. So in terms of the 4 steps of survivorship care, step 1 is knowing your patient, developing this survivorship journey. Step 2 is cancer surveillance. So in terms of this, patients get a monthly reminder for a breast self-exam. They get a 6-monthly reminder for a clinical breast exam. They get reminders for mammograms, ultrasounds, and they also get a reminder for a recurrence screen. And the recurrence screen is a number of questions that, if you answer yes to any one of those, that would be a concerning symptom for recurrence. And so the patient then gets a red flag and is notified to follow up. And all of these come with graphics that are accompanying them. Step 3 of survivorship care is the side effects of treatment and the management of that. And so at regular cadences, patients would get things like anxiety and depression quick screens. They would get questions for compliance, or are you taking your endocrine therapy? Because we know that it's very difficult for a lot of women to take these. They don't actually take them. And there's screens for typical side effects that you might have from treatment. And there's a library or resource within the tool, so that if you say, yes, I'm having troubles with fatigue, you can go into the library and look up and self-manage, because there's good peer-reviewed literature in there. And so there's tons of topics that are covered in this resource library. The last step of survivorship care is health promotion, and we often forget to do things like PAPs, fit tests in these patients, and so they will get reminders for these as well. So why use this tool? I think in this day and age of healthcare, when we are really stretched, we have to think outside the box. And so the thought with this tool is, do we really need to see these patients every 6 months in the cancer clinic or even by their family physician? Are we actually remembering to order the right things and do the right things? Should we be sort of dealing with a just in case model, or should we be dealing with a just in time model? And so by putting patients on a digital care plan as opposed to an in-person care plan, you're freeing up space in the cancer system. You're allowing people to come in who need active treatment and have space for them there. You're tracking what the patients are doing, so you have data on whether they're actually accomplishing things. You're empowering patients. You're telling them exactly what they need to do for their care, and you're giving them a good resource library for anything that they might run into. And it's modifiable. If things change, you can change the prompts within the app. So where are we at with this? We've been approved by TOH for use. We are working on Epic integration. It's been really slow because there's a long list of projects wanting Epic integration. Because we didn't get Epic integration, and because I did apply for a Tehama grant but was not successful, we had to find a way to onboard people onto the app. And we didn't have the capacity to do that in the Wellness Beyond Cancer Clinic. And so what's come out of this is kind of a really nice side benefit, I think, is that we partnered with the Ottawa Regional Cancer Foundation for pilot implementation. And the Ottawa Regional Cancer Foundation is an arm's length from the cancer system, but they are really looking to engage more with the cancer system. And their focus is really on wellness and a lot of survivorship care, and they're linked to a lot of community resources. So they have jumped on board with this. They're super keen to be involved. And they have 2 navigators there who are onboarding our patients. And so we are going to be starting next week with the very first patients. And what's nice is patients will flow from Wellness Beyond Cancer to the Ottawa Regional Cancer Foundation and will be linked to community resources when they're there. So it's TBD. We're really just about to go live. And what I'm hoping to do is to be able to use the data that is generated by this tool to look at the quality of care and patient input to be able to kind of take some research out of the efficacy of this. So just one last thing, because I know we're probably almost out of time. I wanted to just flag this project because I would really like people's engagement and ideas and help with this. This is not a research thing, but I'm just using this as a gratuitous moment to throw this out there. So as regional primary care lead, we've been working very hard within the regional cancer system to figure out how to allow unattached patients to get cancer screening. And we have managed to turn one of our nurse positions into a nurse practitioner position. And she is going to be our super screener that can provide cancer screening to all unattached patients in the Champlain region. So we've just hired her. She's just started. We're just in the middle of onboarding her and educating her, getting up to speed, and mostly getting her an Epic access. But she will be working to liaise with community groups, indigenous programs, healthcare partners throughout our region to increase screening in underserved populations. So we'd be thrilled if she could go into more rural communities, partner with clinics there, do the screening. But the nice thing is she will manage all of the abnormal and all the screening results. So there'll be system management in place for all these things. So we're looking for partners for her to partner with. So please email me if you think that you might be able to help with this initiative. We're super excited because right now there's probably 150,000 people in our region who don't have access to screening. From a research perspective, I'm really keen to see how this kind of role will help with our numbers, because I get quarterly reports for Cancer Care Ontario, I know exactly what our screening numbers are for the region. It'll be really interesting to see if we're able to bump those up and perhaps use this as a model for the province as a whole. So questions? Happy to entertain.
Anna, thank you so much for that wonderful overview of all your scholarly endeavors. That's fabulous. If I could just start, I can see that Lise had put in the chat just a couple of follow-up questions. I think you addressed them. I'm not sure. Are you satisfied with those responses, Lise?
Yeah, I think so. Anna, absolutely fabulous work, just amazing. I'm just wondering about community docs, because there was a lot of epic talk. I'm transitioning into the community from TOH, and I'm trying to provide, make sure there's no gaps in care for patients at all levels. And one of the issues is people's access to things that are kind of epic, special, so just wondering about that part. But I understand it's a very early stage, so maybe that's too early as a question.
No, I don't think so. So essentially, the only role for Epic in this tool is to put the patient's treatment information in the first place so they can have a customized care plan. So beyond that point, it's not linked to Epic in any way, shape, or form. And the goal is for it to be used by all breast cancer survivorship patients in our area. And it is not Epic based. It will just give them the reminders for the care they need. And it doesn't, unfortunately, the goal initially was to then have it link back to PCP. However, I was very naive in thinking perhaps this might be feasible because there's about 1,000 EMRs. So that's obviously something that we'd like to think about in the future, but it's not that straightforward.
So from the clinician view, is that an app that the family doctor has on their iPad, or it's a website they have to log into? Like how do if you I've got a breast cancer patient, and how do I access that information?
Right, so that the clinician view is held by the cancer center. So it's not held by the individual family physician. And it's really just the list of patients that are on it and the onboarding ability. So this does not feed back to family physicians or at this point. The clinician dashboard can be very much modified to allow anything with a red flag to be notified. But for medical legal reasons, right now we've decided to turn it off just because we don't want to be responsible for everything coming in. But I think this is a future. I think as ocean becomes more and more prevalent, this might be how we manage to do that. But to start off and just get it going, we're just keeping it very simple.
Okay, excellent. Thank you.
Claire.
Thanks, Anna. Congratulations. I think the impact that you're having is tremendous. And yeah, you should really continue to be proud of the moment when you heard that your paper was presented at a huge American, and I'm sure it was an international attended meeting. So I think you've demonstrated and are continuing to demonstrate how powerful it is when a family doctor has an area of focus and then pursues that over time. And so keep going with it. I invite you to do, and actually I'll be reaching out to do a follow-up. Let's work together for your next stage of support and funding. I'm very keen to look at how we can do that and help keep going with sort of the grant application piece. So congratulations, full scope work, really proud of you. Keep going.
Thank you. When you're passionate about something, you enjoy doing it, I think is the bottom line.
I can see there's a few comments in the chat too, Anna. Just again, commenting on the great work that you're doing. So carry
Perfect.
on. Looking
Thank you
forward
very
to reading
much.
more. Okay, we'll actually now transition to our second presentation. Actually, just before we do, I just want to let you all know we're actually thinking ahead to 23-24 for Family Medicine Grand Rounds. So in the next little while, expect some calendar invites for you to mark in your calendar for Grand Rounds for the upcoming year. Our next speaker, Dr. Gary Viner. Gary completed his family medicine residency in 1980 and immediately started family practice in Ottawa, first in solo practice and then evolved into a 3-person group. Obstetrical care has always been a significant component of Gary's practice for over 36 years. He started taking medical school in his practice in 1982 and became one of the community resident preceptors in 91. In 2001, he moved to the Civic and shifted to full-time academics. In 2010, he completed his Master's of Education and became a medical education researcher, developing a national recognized reputation and also becoming the Director of Evaluation until 2019. He retired from clinical practice at the end of June in 2021. And he continues to provide some clinical care and supervision at the Civic and Riverside teaching units, as well as working on this medical education research project that he's going to present to us today. So Gary, over to you.
Thank you very much, Doug. Before I say anything about what I've been doing, I also have to congratulate Anna. Such a relevant, practical, important work, and it's a very hard act to follow. It's truly a privilege to be here. I'm about to share my screen, and hopefully that's now displaying, if I'm lucky.
It is indeed.
Oh, perfect. What I'm going to be talking about today is the result of work that's been going on for 5 years with a wonderful team and is still work in progress. The topic that we're discussing is the impact of electronic health records on patients, the learners' patient-centeredness and virtual encounters. And this team is based in 2 sites, University of Ottawa, myself, Farhad Motamedi, Kendall Noel, Doug has been a part of this as well, and Laura Santos, one of our residents, who I see is on the screen, and it's nice to see all these people on the screen. From the University of Victoria, we have Dr. Lisa Shaw, who's also a physician, but is a PhD candidate, Helen Monkman and Andre Kushnaruk, who are human factors researchers. How did all of this start? Back in 2018, I was appointed as one of the trainers for EPIC. And so as I started to look at EPIC and its complexity, its built-in artificial intelligence and decision support that are a part of it, though we don't use many of those in our current iteration at the Ottawa Hospital, the tremendous visual complexity of the application, and even though I'm very much a technology aficionado, I was very concerned about how this might impact on trainees and their development of clinical reasoning. We did a literature search, which did support the need for this research. And so our goal when we started to commence this project was to identify the degree of impact and perhaps to develop an enhanced approach to training. That literature search demonstrated some controversy over the impact on quality of care and clinical reasoning with electronic health records and potential barriers for the interaction between doctors and patients. Other identified issues came up, of course, in the literature search, and many of these are well known: health provider burnout, the quality and size of the electronic records that are produced, as well as quality because of error persistence, and the impact on patient flow and time efficiency. So we decided to assess the impact of electronic health records by comparing a novice physician or first-year medical resident in family medicine with experienced physicians, and to use simulated encounters so that we standardize what was happening. We had this incredible research team that we started off with. We had engaged the Chief Information Officer, Dr. Glenn Geiger, at the Ottawa Hospital, as well as Jerry Maniatti, who at the time was VP of Education at the hospital. We had from Department of Family Medicine, our chair at the time was Diane Delva, and we had directors of both research and evaluation. At the Civic and Riverside, we had the unit directors, and we restricted this to the Civic and Riverside because they were the only two units that were using EPIC or were to be using EPIC. And then in addition, because I had a pre-existing relationship with Helen Monkman, who I knew when she was a master's student and had been involved in her research, I had forged a relationship with the University of Victoria researchers. And so they became a part of this, and they're very much involved in human factors related research. And of course, electronic health records are all about how we interact with computers. We made grant applications, and it's a sad tale. We started off with a 2018 Tahamo Innovation Grant, and I had similar experience to Dr. Wilkinson. We didn't succeed. We tried again in 2019. Again, didn't succeed. We tried again in this time with the Royal College of Physicians and Surgeons because we were eligible because of some of the other members of our team for their medical education research grant. Failed again. We applied to PSI, failed again. We consulted the Ottawa Method Center and put in another grant application for Tahamo, our third and final, again failed. So we were pretty sad. It's a sad saga. Despite that, we had some pre-existing funds, and we decided to initiate the project in 2019. We trained simulated patients to be a part of this study. We had research support from the Department of Innovation and Medical Education. I'm cross-appointed there. We had a volunteer research assistant. We were very lucky to have an international medical graduate who had not been licensed here in Canada, moved here from Toronto, that I was connected to through one of my prior graduates from our program. And Laura Santos volunteered her time to work with this project. Fortuitously, she ultimately got into our program and is about to graduate this year. And I have to give credit for some of these slides because she presented her work at Meredith Marks Day that's part of this project. And so you'll see a couple of her slides and perhaps a picture of her. We had planned to put 15 participants in each group just based on the size of our program, 15 first-year residents and 15 experienced family physicians. And we'd reassess the 15 residents 6 months later in these scenarios. We continued at the same time to get grant support, and we finally succeeded in 2022 to have Dr. Motamedi obtaining a prime grant to support this work. We decided to use SU exams as the source of our scenarios. These have great detailed background in history for any simulated patient. And of course, these patients were going to be unknown, or the scenarios were going to be unknown to the participants, much like a SU. They have built-in clear acting instructions. They have an evaluation schema. They've been well tested and validated. But the problem with a SU, of course, is it's designed for a doctor-patient interaction without a computer, without keeping any records of what was happening. And of course, there's no pre-existing information. And so we had to find a way to select a SU scenario where we could embed some history and results into an electronic health record so that we could watch how people interacted with the computer. We also felt that a 15-minute session was not adequate, especially if they were going to be interacting with the electronic health record. So we did have to adjust the SUs and adapt them, not only by adding information in the computer, but to give a little bit more time to the participants to do this work. And we gave 5 more minutes for the interaction process and 5 more minutes for documenting. And we piloted this with dry runs and simulated patient training in November of 2019. So just to give a sense of what these scenarios were, we had a male scenario. This is a 29-year-old man who was presenting with headaches that had commenced after a minor motor vehicle accident 2 years earlier. But the underlying history here also included that this fellow is a untreated schizophrenic and an electronic chip designer who believed that a chip was inserted in his scalp laceration that was repaired in the emerge to control him. And we had to fabricate a CT scan and emerge visit in the electronic health record to help with the background information in EPIC. Our second scenario was a female who was a 32-year-old who was quite upset that the hospital had and the team that was looking after her estranged dying father seemed to expect that she had to take him home and live with her. But she had a very complex social background. It's a typical Sioux. She had a previous history of drug abuse and prostitution, but now happily married, very religious with 2 young children. But then in addition, also needed medical care for a newly diagnosed 3rd pregnancy. So complex scenarios that allowed us to talk about these things. And of course, then all of a sudden, this strange thing occurred in March of 2020. COVID struck and changed everything. No more face-to-face encounters, research projects all on hold, and we had to restructure. We realized that virtual care was going to be required, so we included that as a focus. We had originally been planning on just looking at clinical reasoning. We restricted that now to patient-centeredness, which is in some fashion a component of clinical reasoning. And we realized that the impact on patient-centeredness has not been described in the medical literature. Our research team evolved. We left behind the leaders at the Ottawa Hospital who were no longer interested. And of course, Dr. Delva left Ottawa as well. And we ultimately also were joined by a new physician in University of Victoria who was doing a PhD in human factors. Just a little bit of background around why we chose to do this. Of course, we all know that virtual care has come to the forefront, especially because of the pandemic. And it's really changing access to care and making things much more accessible. So we think it is an important thing to be researching. And of course, patient-centeredness, we all would recognize Dr. Ian McQuinney and the fact that patient-centeredness is all about being able to see illness through the eyes of the patient. And I credit Dr. Santos with this slide. Yoda says the greatest teacher failure is, and I think that's true for how we felt about much of our approaches to grant application and as well as these research questions. We finalized our research questions to 2. How does the electronic health record impact patient-centeredness of first-year family medicine residents versus experienced physicians during a virtual clinical encounter? And are the experienced physicians more patient-centered than the residents during virtual clinical encounters? This was intended to be a mixed method study. We did a lot of qualitative information gathering for human factors related research. And then we also were taking patient-centeredness measurements as well as cognitive load that produced quantitative data. Our population, as I've already mentioned, were the Civic and Riverside family health teams because they all used EPIC. And we were hoping to just do first-year residents, and the experienced family physicians had been in practice for more than 5 years. As it turns out, we had recruitment issues, and so we did include some second years. They were intended to be Zoom encounters, so virtual encounters. The participants were all in their individual private settings, which may have been in a private exam room office or at home. And our simulated patients were all at home and seemed to be uninterrupted based on all the observations from the videos. The two simulated patients were each given a single scenario, and we used these standardized scenarios so that it would negate the variability that might occur in a real encounter and or alleviate privacy concerns, so that there was some standardization. And as already mentioned, we used College of Family Practice simulated oral exams for the scenarios. We ultimately closed the project after having had 10 residents and 6 staff physicians with 2 sequential virtual encounters over the period of a year and a half. We found that recruitment was very difficult. Residents seemed to be very busy people. And so that it was hard to coordinate them with our simulated patients, and we were never able to go on and repeat 6 months later. They all were not necessarily at the beginning of their residency. But each session started off by collecting their demographics and clinical experience, and some questions about their expertise with electronic health records, confidence with IT and virtual encounters. We would then have a virtual encounter with the patient. That would be followed by the patient, simulated patient, and the participant filling out questionnaires on their perceived patient-centeredness and a cognitive workload questionnaire. Then a second virtual encounter followed by the same questionnaires, and then finally a post-session interview. So what we're now about to talk about are our preliminary results. Of course, we've got the demographic information and electronic health experience data. We have the survey by the simulated patient of their patient-centeredness. We also have the survey by the participant of their self-assessed patient-centeredness. We haven't looked at that data yet, but we know that's likely not to be all that reliable. Self-assessment by physicians of themselves tends to be very poor, so we haven't looked at it yet. We scored each of the encounters by experienced physicians who do assess SUS, and we had 2 physicians assess each of these interactions. We also have looked at the cognitive workload scores. The testing we used was NASA's task load index, and I'll report on that. We have not had the opportunity to complete our analysis of the qualitative information, the interview, the video record of electronic health record utilization, the participant-patient interaction, and then finally, we haven't done all of the cross tabulations that would be relevant to look at, though we're dealing with small numbers, so it may not be all that significant. This first slide of results was presented by Dr. Santos as part of Meredith Marks Day, just almost 2 months ago. And this slide demonstrates that from the perspective of the simulated patient, in terms of the patient-centeredness scores of the participants they viewed, there was a significant difference between the residents in blue versus the experienced physicians in purple. And it's counterintuitive, but in fact, the higher the score here, the less patient-centered. So that experienced physicians were significantly better for the male case. Though there was a difference in the female case, the result was not statistically significant. And this is just solely based on the perceived patient-centeredness from the simulated patient. From the point of view of the SU scoring, where we, of course, during a simulated office oral, and we use these in certification exams, we are primarily assessing patient-centeredness. And we only looked at those components of the score that the examiners provided. So the audiovisual recordings were reviewed by 3 different SU examiners that have all done this many times in the past. We were all working independently. We did not do any prior validation training. One examiner assessed all 16 sessions, so 32 encounters, and examiner 2 and 3 each did half. We were able to demonstrate a high level of concordance of the scores, particularly with the female encounter. It was somewhat more variable with the male, and we attribute that to the complexity of assessing a schizophrenic and determining what was going on in a virtual encounter. When we actually looked at the results of this using an independent samples test, and many thanks to Doug, who did the statistical work here, we can see that the experienced physicians in yellow versus the residents in blue, that in both cases, the male and the female case, the scores for the experienced physicians were significantly higher than that of the resident, and these did demonstrate statistical significance. And we can show that graphically as well. This is the male score with the on the right, the experienced physician, and the resident on the left, and similarly with the female. We are able to show these differences. On the other hand, when it came to the cognitive task load index, there was really no significant difference between the stresses of working with the electronic record as perceived by the participant between the experienced physicians and the residents. And so the scores actually proved to be not significant. That we found was quite interesting, and but we haven't analyzed it further yet to look at comfort or cross-tabulated that with them. With regard to the qualitative analysis, this is a much bigger undertaking. First of all, we had to review the data management. We had data management issues because the automated transcripts that Zoom does needed to be corrected and listened to with very careful ears before you actually start to analyze them, which is very time consuming. But the review of the audiovisual record meant observing the detailed interaction with the electronic health record. So what field is being used at any one time, what's being clicked on, what data is being entered. It's a very laborious task. And then with this process, you need to code the observations. And our Dr. Lisa Shaw has been doing all of this work. She's broken it down into 5 different categories for coding these transcripts. So cognitive codes that relate to decision-making and reasoning, usability codes that relate to basic human-computer interaction and workflow, communication aspects such as issues or problems with communication and patient-centeredness, signs that the participant was overloaded, using filler words, repetitive words, stuttering, mumbling, restarting sentences, nonverbal signs, and then missed nonverbal signs where the participant seems unaware of something that a patient has had to say. So we only have preliminary qualitative observations. to report on at this point. But some of the observations that Lisa's made are that the more that the participant was interacting with the electronic health record, the less patient-centered they appeared to be. And they also seemed to be more overwhelmed. This was a little bit less so if they were just entering notes, but much more so if they were searching for data or creating orders, that sort of thing. And they really, her sense was that the residents appeared much more distracted by the electronic health record than the experienced physicians. But this is quite incomplete because she hasn't seen all of the experienced physicians' records yet. So as I said, this is a work in progress. We start off with a smaller sample size than we had anticipated, but not surprisingly, experienced physicians are more patient-centered than our residents in virtual encounters when they're using an electronic health record. And that's whether it's scored by observers or as perceived by a simulated patient. As I've mentioned, we haven't finished our cross tabulations to look at the participants' comfort with the electronic health record or their experience with SAME. And there may be some evidence based on the selection of our cases that some conditions may be less appropriate for virtual encounters. Our future directions at this point, of course, we want to complete our qualitative analyses and cross tabulations, but we're hoping that this will help us reaffirm the importance of teaching patient-centeredness during training. That tends to go by the wayside at times, but as well, we want to be able to identify possible improvements in training on electronic health records for use during encounters. It's clear that we're not doing that very well. We assume people know how to use them. And finally, because SUs themselves are not realistic in the sense that nowadays we are using computers with all of our encounters in almost all environments, we may need to shift how we do certification and how we evaluate residents. And so the college may be interested in this as well. So I have a long list of references if people are interested. I want to thank you. I do have extra slides if there are any questions, but thank you for your attention.
Gary, thank you. Great presentation, certainly one of persistence, telling the story, one of persistence and one of adaptability for sure. So thanks so much for that. We're just about out of time, but I think we have time for a question or two. Alan.
Hi, Gary. Can you hear me?
Hi, Alan. Yep.
Very great, awesome presentation. That's a really interesting project. I found it very interesting. I just have a quick question about what kind of data did the residents have to interact with? Because when you're doing a SU scenario, as you rightly say, there is no data, and it's done. I'm just wondering what they had to look at.
So basically, with the female case, there was no data, and because she was a new patient to the area. With the male case, because he'd had an emerge visit 2 years earlier, had a CT scan that was fabricated and put into the system.
Okay.
There was data for them to look at if they choose to find it.
Okay.
Okay. I mean, not all of the residents did that, but there was data there for them to look at and to see how they were interacting with the computer.
Okay, great. Thanks.
Lise, I see you've got a question as well.
Yeah, thanks. Thanks a lot, Gary. One question I put in the chat, and I know it's probably beyond the scope of the study, but I really like the cognitive load assessment, and I think it would be, I don't know if you have data across different EMRs, but I think that would be really interesting and perhaps might help people choose, at least those who are out in the community and have a menu of EMRs to choose from. It'd be really good to know what's the cognitive load associated with EMRs. So maybe that's sort of an idea for future project. But the main comment I wanted to make was there's one thing that jumps out at me, which we haven't discussed, and it's the difference between males and females, and the fact that, in fact, the PGY1 female residents performed as well as the experienced male physicians on patient-centeredness, if I'm reading your data correctly.
No,
And
that's not actually quite right. We had male and female
like
cases. I haven't separated out the data as to whether the participants were male or female.
oh, so the male and female was the patient case.
Yes, yes.
Ah, okay, because I was like, wait a minute, this is okay. Because my next thought was, do we need to give male residents supplemental patient-centeredness training, right? If that's so that's a bit okay. I misunderstood your slides there. So it was the female case and the male case. Okay,
yes.
It would be interesting perhaps to look at the participant, like the people who were evaluated.
I absolutely agree. That's
right.
part of the cross tabulation that we'll be doing.
Wonderful. I look forward to that result. Thanks so much, Gary.
Thank you.
Okay, well, that's about all the time we have, everyone. Thanks to our speakers today, both Anna Wilkinson and Gary Viner, two great presentations. And I look forward to seeing you all in June.